It was love from the first online speed date, the chats, the swag, but also, have you seen these men? I mean,
Good morning, everyone, and welcome to the second day of our adolescent event, What's New in Adolescent Research Innovations in Adolescent Healthcare. It's lovely to have you here with us again. I see lots of familiar faces from yesterday, so I'm so glad that you've come back. And also welcome to the people who are just joining us for the first time today. I'd like to say thank you to our funder, IAVI, again, International AIDS Vaccine Initiative, who've made this event possible. And we're looking forward to an exciting day ahead. Yesterday, we focused on some of the new products that are available and will soon be available, and how we ensure access to these, and how we also make sure we keep the people who need these products front and center in the services that we deliver to them. We also had 2 workshops, one on demand creation for products, and one on understanding sexual orientation and gender diversity and thinking about how we integrate this into adolescent healthcare services. Today, we've got some other new and exciting topics. We're going to be looking at the important subject of non-communicable diseases and some of the risk factors for these, and how that intersects with the work we do in HIV prevention and treatment. We also have a session on adolescent sexual and reproductive health, and some sort of new innovative topics within that, under STIs, and also looking at sexual pleasure. And then finally, we've got a session on digital health innovation for adolescent health. We're going to kick off now with the first session on non-communicable diseases and risk factors. And it's my pleasure to welcome our first chair, Dr. Amith Ramcharan, who's a pediatric endocrinologist at Red Cross War Memorial Children's Hospital in Cape Town. After successfully completing his fellowship in pediatrics and child health in 2010, he joined the pediatric department in Pietermaritzburg as a general pediatrician. During this time, he developed a keen interest in pediatric endocrinology and later joined the pediatric endocrinology training program at Red Cross. In 2017, he pursued his interest in metabolic medicine and accepted a fellowship in this subject at Great Ormond Street Hospital for Children in London. His goal as both a pediatrician and an endocrinologist is to provide holistic and comprehensive child and adolescent care in a resource-limited environment. His areas of interest include adolescent health, metabolism, diabetes technology, DSDs, and growth disorders. Well, welcome.
Good morning, everyone, and thank you to the organizing committee for extending this invitation for me to be the chair at the session. So our first session for this morning is non-communicable diseases and risk factors associated mental health concerns. And to kick off this, we have our first speaker. Her name is Dr. Simiso Sokhela, and she's a medical doctor with over 20 years experience in both public and private healthcare. She is currently a director of clinical research at Ezintsha at the University of Witwatersrand, with a special interest in HIV, infectious diseases, and non-communicable disease research. Today, I'd like to invite Dr. Sokhela to present her topic on weight gain on ARVs. Dr. Sokhela, the floor is yours.
Good evening, everyone. Thank you to the organizers for having me. And I think I'm more excited about the fact that I'm the first speaker for the day, so that everybody else who comes after me corrects everything that I said that was incorrect. And when I woke up this morning, I was dismayed at the weather. What's with your weather, Cape Town people? Yesterday it was sunny, and then all of a sudden this morning, I thought I could outdo Linda Gale Becker's African dresses, but it is what it is. So yeah, next slide, please. These are my disclaimers. Yes, next slide, please. So I'm just going to, next slide. Oh, yesterday I had people saying next slide, please. So I was excited that I'll continually say that today. You've just stolen my joy. All right. So we are briefly going to look at weight gain and obesity in adolescents. Then we are going to talk about whether HIV affects weight, whether ARVs affect weight, and we are going to zoom in on the pediatric and adolescent population and talk about the consequences, which then leads to the speakers who are going to talk about NCDs. So adolescents, we've all been adolescents, or we are adolescents at the moment. It's a phase in life that is characterized by rapid physical growth. One of the articles I read said that actually some people double their weight during adolescence. So it is a phase of life that already is characterized by rapid physical growth. And childhood obesity is a major public health concern. Actually, it has gone on to be called an epidemic on its own. Childhood obesity seems to have plateaued in the high-income countries, but it's increasingly, rapidly increasing in the low and middle-income countries such as ours. And you'll note that with the rise in obesity, there's a rise in healthcare costs because of the consequences of obesity. So it is something that we need to look at. The estimations are that 22 million children less than 5 years globally have obesity, and 1 in 10 children are overweight. That slide is just a simple estimate of the prevalence of pediatric overweight and obesity. So these maps are actually showing the proportions of children and adolescents that are living with overweight and obesity. This data was taken from the Global Obesity Observatory in 2022. Now, you must note that the data may not be comparable because of the differences in survey methodology within the countries. But if you look at our country, we are down there. We are actually sitting at a prevalence of about 22.5 to 30% of overweight and obesity in adolescents and pediatric populations. The girls, similar patterns, but it looks like if you look at the colors, the problem seems to be identified more in girls than in boys. So the curse of being a woman. The etiology, what causes this weight gain? We do know for a fact that the etiology is multifactorial. There's not one thing that you can pinpoint and say, this is the reason. We've got genetic factors, we've got environmental factors, we've got behavioral, psychological, physiological, and metabolic factors. There's a complex neuroendocrine interaction that controls the energy metabolism. So it influences your food intake and how you burn your food. And some of these things are literally out of your control. Intrauterine growth patterns do affect obesity in adolescence and childhood. Increasing birth weights, normal patterns of insulin resistance that occur in adolescence can sometimes be predictors of obesity later in life. Early menarche has been associated with an extent of obesity. Poor socioeconomic status is associated. And of course, our eating habits and physical activity habits also do cause childhood and pediatric obesity. The one thing we must note, I think it was in my first slide, is that childhood obesity predicts presence of obesity in adolescence. And that represents a strong predictor of obesity in adulthood. So we have to deal with it early on because it has that ripple effect, all right? So we are done talking about whether there is a problem of overweight and obesity in adolescents. We have clarified that there is. It's an epidemic of its own. But now, HIV. Does HIV affect weight? These pictures, some of you might not know because these were from an era when some of you were not born yet. HIV back then was known as a wasting disease. We all know the nicknames that were given: Omo, Imonyora Mafura, Imonyora Ditsila, because the people always looked very thin and gaunt, and then people said, oh, they have Omo. Yes, Omo, the washing powder. We all know that, right? We all have those nicknames of HIV wasting because HIV at the time was known as an HIV wasting disease. The cause for the wasting is multifactorial, like you can see there. Advanced HIV disease, as most people presented with opportunistic infections like candida that would make people not able to eat. It would present with malabsorption syndromes where people are not able to digest and absorb the food that they are eating, the little food that they are able to eat. There could be depression that causes poor appetite because, of course, you are sick, you are wasting away, and the whole world is talking about you. Then we knew that there was an increased resting energy expenditure from HIV, an increased metabolic demand. And so in our clinics, we saw people that looked like that, which is no longer the case. Because everybody starts ART as soon as they are diagnosed, before they lose weight, before all of these inflammatory processes have kicked in, we now do not see this picture that often. I'm saying that often because there are still people who are presenting quite late with advanced disease because of stigma that we still have to deal with. Lately, I think these slides were twisted up. Lately, what we have seen is weight gain on ART, the opposite of the weight loss that we're seeing from HIV. So when people start ARVs, they have not lost that much weight. The inflammatory process is ongoing, but when you look at them physically, they have not necessarily lost that much weight. So the first reports that we received around weight gain were around 2017, I think, when the new generation ARVs were linked with some form of weight gain. Most of the modern drugs are implicated, but it is worse when you look at the newer integrase inhibitors and TEF and rilpivirine, which is an NRTI. Notably though, weight was not reported in registration studies, which was alarming to us when we discovered that people were gaining weight, because in the registration studies that were done, no weight problems were actually reported. And when we went back to request weight data, we were informed that weight was not collected at all visits, which was very strange. I mean, for HIV, which was a wasting disease, weight should have been there. And the registration studies were not done in relevant populations. They were done mostly in gay white men in Europe and the US. But we know that our epidemic is different and that we've got more women, Black women, that are on ART in our populations. So what's the evidence of weight gain? I will not bore you with science, some of which I never understand anyway. But those are the list of studies that actually confirmed that you can gain weight on ARVs, right? It's a list of studies, as you can see, it's a lot, but I want us to zoom in on the last portion where it is written PrEP. PrEP studies have confirmed weight gain. So you do gain weight on PrEP, not only when you have been diagnosed with HIV and have started antiretroviral therapy. It's important that we note that because we are pushing the PrEP agenda. We are looking for an AIDS-free generation, and PrEP is one of the modalities that will get us there, but we are going to have people presenting with weight gain on PrEP. It is going to be even worse because adolescents are gaining weight. Remember, we've said adolescents are gaining weight because of adolescence. Then you add PrEP, which means they will gain even more weight than they would have. Advance, the study that made most of us famous. We enrolled ART-naive people on antiretrovirals, 3 arms, 2 containing DTG, and another one, the standard of care at the moment, which is efavirenz. And up to week 144, you will see that the average weight gain on efavirenz was about 5.5 in women, 2.6 kg in men. I didn't press, it went off on its own. For the TEF arm, the weight gains were alarming, that it was 12.3 kilos in women and 7.2 kilos in men. Now, we must also understand that the weight gain was not just in kilos. We then had treatment emergent metabolic syndromes that were identified more in women than in men. There was a multivariate analysis that was done by Sachs, and he published in 2020. He pulled in 8 randomized phase 3 clinical trials on first-line ART between 2003 and 2015. And if you notice, almost all antiretrovirals are associated with weight gain. All. If you look at the third arm, there's TEF, there's abacavir, there's TDF, there's zidovudin, there's BIC, DTG, there's groupings here of integrase inhibitors, PIs, and NNRTIs. And all classes of ARVs do cause weight gain. It is not a specific class. Some classes more than others, but all classes do cause weight gain. So what are the risk factors to weight gain? Unfortunately, being a Black woman is one of your risk factors, and it's unfortunate. The other risk factors are that if you are on TEF, you are likely to gain more weight. If you start your ARVs with a low CD4 count, you are likely to gain more weight. Part of the phenomenon might be a return to health, but in advance, we proved all the ones with a low CD4 count had the higher weight gains. And what works for weight loss is actually drugs like TDF and efavirenz, which cause you to lose weight. They don't necessarily cause you not to gain weight, they cause you to lose weight. So it looks like it's a dampening effect. So the people who are on TDF and efavirenz don't gain as much weight. If you look at that side, it is the same thing, CD4 less than 400, high viral loads at baseline, a BMI more than 25 if you are a woman and you're of the Black race. The lower box is the drugs that cause the most weight gain. And if you can see there, TEF versus abacavir had the highest odds ratio. What we did in 2022 is that we recalled all the patients that we'd seen in advance, right? The ones who had gained weight on TLD, TAF, and TEE. We recalled them back after we had referred them back to the clinics. They were all switched to TLD in the clinics, and we wanted to see the switch, did it cause any changes in the weight? And alas, all the patients who were on the TEF arm that we recalled back, they had actually lost weight because they had stopped TEF. But all the patients who were in efavirenz, which remember we said causes you to lose weight, once they stopped the efavirenz and were switched to TLD, they actually started gaining the weight. So all antiretrovirals have a role to play in weight gain, but the efavirenz arm, because of efavirenz, had been appearing to not be gaining weight. In actual fact, it was lost because of efavirenz. There are lots of other studies like Opera that singled out TEF as an agent that causes weight gain. Africos, which was done in Uganda, Kenya, Tanzania, Nigeria, where patients were switched to a TLD and their weight had gone up. So what are the mechanisms of weight gain that we think are responsible? Is it a return to health phenomenon? Remember, we said there's high energy expenditure in advanced HIV disease. So once you start ARVs, is it that your body is going back to its healthy subset? Or is it specific classes of drugs like integrase inhibitors and possibly TEF? Is it that the old ARV drugs actually inhibited weight gain more than them not causing the weight gain? We know that from the study that was done by Grisel at UCT, using some of the advanced specimens, weight gain in slow metabolizers of efavirenz was possibly a side effect. Is it an increased appetite and an increased calorie intake that causes people to gain weight? We looked at the food intake that people were reporting. Unfortunately, we don't have tools, validated tools that are able to check weight food intake retrospectively. And people can't remember what they ate whenever. So we were using averages of how many fast food meals did you have? What's your staple? And we realized that people actually are not eating any differently when they are in ARVs than they did before. Is it reduced physical activity? We know that we now take Ubers and we take Bolts from the door of our gates. We no longer walk. We don't want to go to gym. It's not safe to jog after hours. So is it reduced physical activity that causes us to gain weight? Is it more lipid storage or improved fat quality that's causing that? Zooming in on the pediatric population, I will say that there's very limited knowledge about weight gain on adolescents because we are not studying that population. One of the problems that need to be sorted out is adolescents and children being involved in clinical trials so that we can get that kind of data. We are making inferences from adult data, but not necessarily that there is data on those populations. A quick run through these slides. This is DTG uptake in the world. And you can see most countries have actually introduced DTG for children from 3 kgs onwards, and our country is from 20 kilograms at the moment. So we are going to have issues. And what are the complications and what are the things that need to be done? We need to normalize the body weight before the onset of puberty, like I said. And obesity in adolescents is associated with cardiovascular disorders, metabolic disease, psychological issues, neurological issues, non-alcoholic fatty liver disease, pulmonary disorders, and renal disorders. There's even a link with increased risk for certain kinds of cancers. Let's talk about stigma. Stigma around obesity and overweight is a problem at school and at home. So as parents, we don't need to do the stuff that actually exacerbates the stigma at home, but schools as well. Children are reporting bullying because of weight. The implications I've already mentioned, short-term and long-term implications. So what are the conclusions? We now know that HIV is independently associated with weight gain, that the modern ART regimens are actually responsible for some of the weight gain. Overweight and obesity affect all HIV treatment outcomes. The etiology is multifactorial, and so the approach should be the same. There's no one-size-fits-all approach. And our understanding of the issues around adolescents is very poor. We do need longitudinal studies to study the prevalence, the incidence, and the pathogenesis of obesity and weight loss. Thank you.
Thank you, Dr. Sokhela, for that amazing talk. I don't think I need to present because you've presented most of my work already, so maybe I'm off the hook. But without further ado, I'd like to introduce our next speaker. Her name is Dr. Janetta Harbron. Dr. Janetta Harbron is a senior lecturer in nutrition and dietetics at the University of Cape Town, with a particular interest in obesity and non-communicable diseases. She's also a collaborator on the Co-Create, a project which brings together 14 international research and advocacy organizations to work with young people to create, inform, and promote policies for obesity prevention. Ladies and gentlemen, I'd like to invite Dr. Janetta Harbron to present this work on Co-Create project and adolescent obesity.
Thank you very much. Good morning, everyone. Thank you for the opportunity to present here. So I will talk about the Co-Create project and then specifically drivers of adolescent obesity, what we've done in this project, and also some methods for engaging with adolescents using participatory research approach. So just as an introduction, so we've heard now from the previous speaker about causes of obesity as well. So if you look at the direct causes, diet and physical activities, sleep can also be a direct cause. They are individual level downstream causes. But they are influenced by many upstream structural drivers of these behaviors. So there's environments, the food environment, physical activity environment, and then all other environments with that: social, cultural, physical, economical, political environments. And these environments then affect, for instance, the availability, accessibility, affordability, and social acceptability of healthy and unhealthy diets. Also the opportunity for engaging in sedentary behaviors or physical activity. And these environments are then strongly influenced by policies or programs or interventions that's put in place. So it's a complex system that's involved in obesity. So now you can either have the environment with like these unhealthy things, or an environment where the healthy choice is the easiest, the most accessible, the most affordable choice. But that is then shaped or controlled by policies and programs that should be in place. So things that's sort of outside the control of the individual. So this is what we looked at in this project. We looked at a systems approach and how we can intervene on that level. So I just have one slide on, this is a study, or we looked at previous published data. So it's survey data in South Africa, just to look at our obesity prevalence in adolescents. So if you look there on the top of the those are the surveys that we included. They are different in terms of data collection, approaches, sampling, and all of that. So it's the demographic and health survey, the youth risk behavior surveys, and then the SANAs and another demographic and health survey. The years that the surveys were done. So these are the national stats that we have for adolescent obesity. And those are the sample sizes. And then what we see, let's see if it works, yes. So you can see overweight prevalence in girls in the orange, and obese prevalence in girls, and how it sort of increased over the years, and then for boys. And we compared it to European data where they sort of similar, and the girls, it seems like slightly increased, and sitting around 33.8% combined prevalence of overweight and obesity for adolescent girls. So all in all, there's many systems around us that control the environment. So it's not individual factors or within the individual control, and we need policies for those factors. So this was the Co-Create project, and the overall aim of the project was to contribute towards reducing the prevalence of obesity amongst adolescents. It was mainly focused on Europe, so it was done in 5 European countries, and then we also did some sections in South Africa. So through policy actions to promote a healthier food and physical activity environment. So those were just the partners that were involved. So the project had a policy focus, as you can see, a systems perspective and youth involvement. So I'm going to talk about the youth involvement was from the beginning, from planning the project, even before when we started with the grant application to the European Union. So they were already involved at that stage of the project, and then throughout, they were also one of the partners. There were youth organizations. And then these are just some of the tools that were developed during the project. So what we did in the different work packages, for instance, we looked at available policies. So also in South Africa, so the available food and physical activity policies, this is summarized in a nourishing and moving tools, which is the international database from the World Cancer Research Fund. And so we updated that and then benchmarked those policies. So this was one. I'm not going to talk about that today. Then we also looked at previous evidence, systematic reviews were conducted, and so on. Then we did systems mapping. So I'm going to talk a little bit about that. Then we created groups of youth alliances, and we also did it here. And they were then taken through a couple of weeks, empower them, we worked with them, and we used youth-led participatory action research in that process so that they can develop policy options. And then there was a dialogue forum with stakeholders to further refine the policy options, and then recommendations, and there was also a modeling. It's now not indicated on this one. Okay, so the systems mapping, I'm just going to talk a little about the systems mapping. So this article nicely summarized the method of the system mapping that we use, the group model building method. And then this article was about the South African systems mapping that we did here. And so we use participatory methods. So the aim with these methods is to involve the study participants. So it was the adolescents. And the reason for that is because they are increasingly recognized to be a fundamental part of any research process. And the system mapping was then based on group model building. And it uses techniques of systems dynamics. This is modeling where you model then eventually the effect that a policy idea will have on weight, for instance. And so in the Co-Create project, we use this then to create causal loop diagrams. So what we did here in Cape Town is we included, so this is qualitative research, right? So it's small groups. We included 16 to 18-year-olds in the Western Cape. So this was in the city. We included a low socioeconomic status school. We used the quintile system, so 1 to 3 schools, and then high socioeconomic schools. And then we also selected non-capital, so from towns outside of Cape Town, low CES and high CES. So we included 4 public schools. And from these schools, you have this group of adolescents with 15 in them, about 15 around there. So we had 4 groups and then 62. And this was then also done in all the European countries, the same thing. So then there were these adolescents participated in 2 workshops, 90 minutes each, and they were trained facilitators. So we went for training, a 5-day course in the UK, and to facilitate these workshops. And then during the workshops, I will show you now what we did, but there's also note taking. And then you use the program Sticky to create the maps. And it resulted eventually in 4 maps, so 1 in each school. And then we combined the maps into 1. So these are just the techniques that you use during the session to engage with the adolescents. So there's various, you can see there at the end, it's individual, and then it's group techniques, and then it's small group and a larger group. So they feed back the whole time. And you use these different techniques to engage with the adolescents so that they can tell you what they think are the drivers of obesity. So the first step is, for instance, they had to draw on these cards. So they just had to sit individually and draw any number of these cards, and then about what they think cause obesity. It could be related to diet, physical activity, anything that they want to. And then they had to think back in the past. It could be their past or what their parents or family told them in previous years. So something like this, they said social media advertising of unhealthy, probably refer to food options there. So in the past it was low, and then it increased over time. So this is at present. So if nothing is going to happen, then the fear is that it will continue. If there's some kind of policies or programs put in place, then you hope it will decrease. So this is already then one. Then they can sort of identify, maybe we need something here because there's a lot of advertising of unhealthy food on social media. So they did a lot of these. And this is what is called then the overtime graphs. And then they feed it back in the small group, and then they told us, and they told us the stories as they presented this graph. Why are they saying that? So then the next thing is you put it on a circle like this, all the factors that they thought contributed to obesity. And then the next step is you ask them to draw linkages between these. So for instance, they will say now, but they draw a linkage between the one, this one will cause the other one. And if it's a line, a solid line, it's as the one increase, the other one increase. Or if it's a dotted line, it will be as the one increase, the other one decrease. So then we created a map. So after that connection circle, you create this map. It doesn't look exactly like that. You go after the session, and then you can organize it into different themes, color it, and so on. So it is a bit small, but this was then the combined map of all 4 schools. And then within this map, you identify feedback loops. So you will see there's a loop is forming, for instance. You can follow them to where they go, and then so there's like bigger loops. You can see here's a nice loop going around here. So then they had to take out those loops, and then they can form action ideas of, so they draw it again, and so the idea is when you have a closed loop, it's how the one thing caused the other thing, and that caused the other thing, and so on. So you can't just address one thing, but you must break the loop somewhere. And that can be done with a policy idea or program or so. So then they identified that. So these are examples of some of the loops. I'm just going to tell you a little bit of what they said in some of these examples. So they said if you're doing physical activity, then it motivates you to exercise. Opposite also, if you don't do any physical activity, then you are less motivated to exercise. But then the motivation to exercise is also hampered, and they told stories about community safety, sports opportunities in and outside their schools. This was specifically then related to socioeconomic status, which we'll get now. affordability of gyms. So there was a general believing in all the schools, low and high socioeconomic, that adolescents must go to a gym. So that they were now 16, 17, 18. And they even said, even if they don't have money to buy food, they will save money or try and get money to buy supplements, protein supplements or things like that, because you need that to go to the gym. So the gym seemed to be very important, especially in the males. And then staying indoors was, want to say, okay. So if you're not motivated, as motivation goes up, then staying indoors will go down, or the other way around. And then if you stay indoors, then you use technology. And this is then related to being on social media. So there were adolescents that said, if you don't have a cell phone or you don't have data, then you're dead. You must have it. And they will do things to get, or they will go to places where there's Wi-Fi available, so that they can be online. So then they also said with that comes increased social media exposure, and there's a lot of unhealthy food advertisements on the social media. So then another circle was related to physical activity, health, and I think here was more socioeconomic status also came in here, and opportunities for sports, that's there. So this was not specifically in the low income schools where the adolescents indicated that there's limited sports opportunities. Often the schools only have one sport. There's no regular practice time, no matches are scheduled for them. The schools do not employ coaches, although they know there's people available in the communities that's not employed and that can coach them. So they are, consequently, all of this leads to they are uninterested in sports if it's not available and it's not accessible for them. They also spoke about there's maybe one sport facility in the community, but it's so far from them, they can't get there, and safety against plays a role. So they would rather stay indoors again. So it seems like there was a general thing that after school, they go home and they would rather stay indoors because it's not safe outside always, and there's also not opportunities for sports. In this one, you can see the pink ones is about food. So it was about accessibility of unhealthy food. And this increased then the purchasing of unhealthy food. But they also, what came also in here in the bigger map to accessibility of foods was the access to, is it 3 minutes? Okay, was the access to informal convenience shops. So they said these shops were everywhere in the communities, and then there's unhealthy foods, large portions, it's cheap. It's just outside the school fence, and then they purchase the foods during breakdown or on their way home. And then also advertising of unhealthy foods. So those attractive specials of these fast foods outlets. So like, for instance, that quote says, social media causes laziness. Without social media, you wouldn't see all the KFC adverts, and you wouldn't feel hungry every time you see it. And then there was stress. So stress came up everywhere, and mental health, European countries, in all the South African schools. Seems like there's a lot of stress on the adolescents. It can be academics, workload in the school, from the home environment, home finances. Also, they also mentioned they had to look after younger siblings and they don't want to, and it's stressful for them. There was peer influences, relationships and peer pressures. And you can see there the stress. And then the stress and so on leads to behaviors such as drinking alcohol, fizzy drinks, eating unhealthy foods, and so on. And then the last one was parental involvement. So they said their parents are not spending enough time with them. They fail to respond adequately to their emotional needs. And this was also throughout all the schools. They work long hours, but they understand they must work. But then they are not, they don't really want to cook homemade meals. There's irregular meal times. They don't really watch what they eat, and they don't really worry what they eat. So they will just eat 2-minute noodles and things like that. And they have ineffective communication skills, and there was lack of trust by parents. And this then resulted in attention seeking. So you can see it goes from the attention seeking and affection elsewhere. And this leads to unplanned sexual relationships, teenage pregnancies, use of contraceptives. So they also said that contraceptives, I think, are related to eating more, weight gain, and things like that. And then also this leads to alcohol intake as a coping mechanism and food and overeating. So then I can just so then we did the youth alliances. I'm not going to present any results, but I just wanted to show you what we did there. So we generated policy ideas using these systems mapping. Then you refine the policy ideas with them, and we used the participatory action research. So you empower the adolescents with that. So they become researchers. You train them in using research techniques. So we did photo voice with them. They really enjoyed that. And then they came back bringing the camera, and then we analyzed that, or they actually analyzed it and then decide what they want to do next. There was also interviewing. So they interviewed someone or did a survey. And this all helped them to refine their ideas. And then they had dialogue forums with stakeholders. Okay, so this is all indicated there. And then the dialogue forum was the last one. So I'm going to skip through these. This is just indicated how it's done. And then you invite stakeholders. So it's a 2-hour process. It's almost like a board game that you play in a structured way. So there's a canvas that you can print, and these things are all available on the website. There's cards and moderated sheets and so on. So there's 6 participants, 3 adolescents, 3 stakeholders, and then they discuss the policy idea. And at the end, they come up with action plans of how to take it further. So that's just an example of the canvas and all the tools that you use. Yeah, and so I just want to, so these are supplements in this year that's all about the Co-Create project and all the methods and the website if you want to see any of those information. So these were some members of my team. Thank you.
Thank you, Dr. Harbron, for that very informative talk. I think we will save all the questions for the discussion a little bit later. So if you have any questions, start jotting them down with regards to each of the presentations, and we'll field them a little bit later. So I'm the next speaker, and I've already been introduced. So if we can I have my presentation up, please? So basically what I'm going to do is try and do a brief overview of obesity in the adolescent population. I have no conflicts of interest. And with that, let us get started. So obesity is a complex condition that interweaves biological, developmental, behavioral, and genetic factors. WHO defines obesity as abnormal or excessive fat accumulation that presents a risk to health. It is epidemiologically defined using a BMI where overweight is defined as greater than 1 standard deviation above the reference mean, and obesity as greater than 2 standard deviations above the reference means. Worldwide, worldwide obesity has nearly tripled since 1975, and as already pointed out, it poses a significant health problem. This map has already been shown to you already, but for purposes of my talk, I'd just like to point out that in 2016, more than 1.9 billion people or adults were overweight. Of these, a staggering 650 million were obese. 39 million children under the age of 5 were overweight or obese in 2020. Over 340 million children and adults aged between 5 and 19 were overweight or obese in 2016. Having said all of that, between 1975 to 2016, the global prevalence of obesity increased 8-fold to 5.6% in girls and 7.8% in boys. Rates have plateaued in many high-income countries, but like in countries like ours, the rates continue to soar. And if you actually look at this data published by the Global Obesity Observation Group, you can see that South Africa, both for girls and boys, has a population or has obesity prevalences of approximately 1 in 4 adolescents and children. So those are quite scary statistics, such that certain countries in Europe have actually declared obesity as a chronic illness, and as such will require the necessary funding and treatment to try and prevent this. So weight regulation is a rather complex homeostatic mechanism. In order for us to understand the pathophysiology of obesity, it is very important that we try and have some insight into the understanding of the weight and energy homeostatic mechanisms. Firstly, there are 2 mechanisms that exist concurrently. These include the conscious mechanism, and then there's the unconscious mechanism, which both regulate weight gain or regulate weight, as well as energy homeostasis. I'm going to start off with the simple one, basically the conscious weight regulation and homeostatic mechanisms. So this is the easier one. So here you actually have environment, which we all exposed to, and then obviously our senses, which include hearing, vision, smell, etc. And what would happen is you either see food that you like, or you see food that you don't like, and using all of our senses, these then actually send signals to the hypothalamus, which is the homeostatic, which is the energy regulator of the body, and these then generate signals in the higher brain, which would then actually tell you to eat a food that you like or not to eat a food that you don't like. And this is where Dr. Harbron actually made an important point. Social media, advertisements regarding foods that you probably like KFC, etc., would probably stimulate the conscious mechanism and therefore result in unnecessary intake of food, thereby promoting weight gain. The unconscious energy and weight regulator system consists of multiple hormones that are involved in the regulation. These can be produced by the stomach in itself, which would include some appetite suppressing hormones, or some appetite stimulating hormones. The pancreas in itself could release insulin. The adipose tissue would release some of the hormones, and in particular, leptin. So just to understand this, and I actually can't see my side very clearly, so I'm going to try and take you through it a little bit blindly. So once you actually ingest a meal, at the level of the stomach, some of the hormones would be released. These hormones would then signal the hypothalamus, and this would induce a feeling of satiety. Having said that, there, when your leptin levels increase, that means your energy stores are somewhat adequate. The leptin will then send signals directly to the hypothalamus, indicating that you don't need to consume any more food. Having said that, there, leptin would also then act on the neurons located in the arcuate nucleus, include agouti peptide and NPY peptides. So if leptin stimulates both the agouti peptide and the NGYP, that will actually cause suppression of your appetite, therefore telling the rest of, or telling your brain that there is adequate energy and induce satiety. Also, what leptin does, leptin will act directly on POMC. POMC will then break down into MSH, or melanocyte stimulating hormone, which will then act on MC4 receptors, and that in itself would induce satiety. When leptin levels are low, there is no inhibition of agouti peptide, and as a result, signals are sent such that you promote hunger. Now, whilst these mechanisms are rather complex, any dysregulation of the appetite due to blunted suppression, a loss of caloric sensing signals, will result in obesity. I think the slide has been presented before. So the pathophysiology is polygenic and multifactorial, and unfortunately begins before the conception of a child. These will include prenatal factors. So basically, an obese mother has an increased risk of producing an infant who is going to be overweight. Or for an instance, a mother who smokes will have, these children will have a higher incidence of being small for gestational age. And we know that small for gestational age babies have a higher risk of developing obesity later on. So coupled with an obesogenic environment, epigenetic factors and genetic factors, and in the recent GWAS study that was carried out in over 16,000 children, the study identified that there are more than 25 genetic loci that are associated with childhood obesity. So coupled with prenatal, natal, and postnatal factors, an obesogenic environment, epigenetic factors, and a host of other factors will result in obesity. So the complications of obesity are vast, and unfortunately, if you start to develop these complications, or adolescents who become obese early on, show a rampant progression through complications in early to mid adulthood. As already mentioned, the complications are vast and can range from the brain, where you could have raised intracranial pressure, to the lungs, where you could have, or to the upper airways and the lungs, where you could have obstructive sleep apnea, to the liver, where you could develop NASH, to the heart, where you have an increased risk of cardiovascular mortality, to the pancreas, where you develop insulin resistance, to the bones, where you could develop orthopedic complications. And as you can see, We could go on and on and on with the complications, and all of this actually pose economic burden on a country. And if you look at this adolescent and childhood obesity and excess morbidity and mortality study in young adulthood, which was a systemic review carried out by some of these authors here, they showed that if you actually develop obesity in adolescence, that your hazard ratio for developing diabetes mellitus, cancer, hypertension, and cardiovascular morbidity increases by 1 to 6 hazard ratio increases. So you can see that by age 45, so you can see that the complications will eventually develop, and they will develop rapidly. Having said all of that, they're rather unspoken about complication with regards to obesity is the complication of mental health issues. So obesity in itself will actually, well, you can see there's this bi-directional flow with regards to mental health and obesity. So you can see that obesity in itself will result in body dysmorphia. Body dysmorphia will then actually result in depression. Having said that there, if you're actually depressed, you're going to gain weight. If you have certain types of depression, or if you actually have other problems, other ongoing psychosocial stressors, you're going to develop an eating disorder. And with that eating disorder, you're going to be more obese. And with that, you're going to actually be depressed. With obesity comes sleep problems. If you have sleep problems, we know that interferes with your mood. We know that if you actually become depressed, you're going to become obese. So it's this rather vicious cycle that actually has no end. And we need to promptly identify and treat these patients with obesity in adolescence rapidly. So as I've already said, the complications are vast, and we need to start screening for them rapidly. This would include screening for dyslipidemia in the form of a fasting lipogram annually. We need to screen for hypertension on at every single visit, and we do this by measuring their blood pressure. We need to screen for diabetes mellitus with an HbA1c or fasted glucose, and if necessary, an oral glucose tolerance test. And this should happen on an annual basis. You should also monitor for fatty liver disease. And of note, in developed countries, fatty liver disease is one of the increasing conditions for a liver transplant. We do this by measuring an ALT or a transaminase along with an ultrasound, and this needs to be done on an annual basis. Obesity is also associated with renal disease, and we need to monitor for proteinuria. We do this by measuring a urine creatinine ratio in the morning on an annual basis. Remember, don't forget about some of these other complications such as obstructive sleep apnea. And here you need to ascertain a history of chronic snoring or daytime sleepiness, or even depression. And we do this by doing sleep studies, and the frequency is as needed. In adolescent females, we need to be cognizant of PCOS, and a history of amenorrhea associated with acne, as well as hirsutism, should actually allude to this diagnosis. We can test for this by doing an FSH-LH and a testosterone, as well as an ultrasound. And we do this as required. And finally, we need to also not forget about the musculoskeletal system. And here patients would present with hip pain or joint pains, and we then need to perform an X-ray of either the lower limbs or the hips, and this is done as a PRN basis. So the treatment of obesity includes both lifestyle intervention, pharmacological intervention, as well as surgical intervention. Now, I want to just allude to this point over here. When we actually treat adolescents who are obese, we need to be very cognizant of how we talk to them. Communication should be considerate of the stigma associated with the term obesity and the use of person-first language. So never say the obese patient, never say the fat patient, or never talk about what are you eating to get fat? Because studies have shown that if you actually use such stigmatizing language, this would be associated with binge eating, decreased physical activity, social isolation, and complete avoidance of the healthcare workers. And therefore, they may develop complications silently and rather late. Lifestyle intervention is the cornerstone of therapy. And here, summary data from multiple randomized control trials of live treatment approaches indicate that interventions that offer 26 hours of face-to-face counseling regarding nutrition, physical activity, and lifestyle recommendations resulted in modest but clinically important changes in the BMI, in the mean BMI score. And this extensive counseling of 26 hours needs to actually happen over a 3-month period. So the nutritional recommendations include the elimination of sugar-sweetened beverages and juices and decrease highly processed foods and snacks. They need to follow dietary patterns that emphasize plant-based foods, lean sources of protein, high levels of fiber, and low levels of saturated fat. They need to eat regular meals, avoid snacking, and control portion sizes. They need to avoid caloric dense food. Meals should be ideally prepared at home, and parents should be actually should display role model eating behaviors. And again, something that came up with Dr. Harbron's studies. So I'd like this so-called traffic light diet. And what this actually shows is that you label foods green, orange, and red. And here, green food would mean that you could eat these foods at any time. Orange would be sometime foods, and red would be once in a while foods. Now, actually putting or designating foods with these color choices in some of the studies have actually shown a statistically significant reduction in BMI. Now, does lifestyle intervention work? Well, the evidence is conflicting. Multiple lifestyle intervention randomized control trials and meta-analysis showed improvement in BMI, a reduction in blood pressure, improved insulin sensitivities, and improved aminotransferases, but the lipid profile remained inconclusive. Now, contrasting this, in a very large real-world German study trial, showed that most participants, particularly in adolescents, did not achieve weight loss, and that 90% of adolescents were actually lost to follow-up. I think more research is needed with regard to this. So what about physical activity? So the recommendations are that you need to have less than 2 hours per day of screen time outside of school and work. Over and above this, you need to engage in 60 minutes of moderate to vigorous physical activity on a daily basis. I'm not quite sure if I'd do that. But those are the recommendations, and you can see it's already a hindrance. So when lifestyle interventions actually fail, you'd need to actually go to pharmacological interventions. And unfortunately, in terms of pharmacological interventions, we have very limited options, especially in the adolescent group. there are, I think, 4 or 5 drugs that are actually approved for use of weight lowering agents in the adolescent population. These would include drugs like Olistat, which inhibit pancreatic enzymes. And here, you're only allowed to use such a drug for a maximum of 3 months. Having said that there, whilst it is associated with weight loss, the side effects are rather devastating, and they include GIT side effects such as flatulence and urgency as well as frequency. And as a result, they're not very well tolerated. Newer agents have been approved, and these would include things like phentermine, which act on your adrenaline axis to improve your metabolism. Again, side effects, these need to be used on a short-term basis, and the side effects are not well tolerated. Of recent, 2 other agents have been approved by the FDA, and these include the GLP receptor agonist in the form of liraglutide as well as semaglutide. Now, these actually suppress appetite at the level of the stomach, but they need to be given as an injection either on a daily or a weekly basis. The side effects include nausea, which is the most devastating side effect, but contraindications include a risk for thyroid cancer. Well, you never win. And then you actually have semaglutide, which has been approved by the FDA for children more than 6 years of age. And these will include its action upon the melanocortica on MSH, which would then act on the MC4 receptor to induce satiety. The studies are still ongoing, and even though it's been approved, we're still awaiting the data in the adolescent population. So interestingly, if you look at this randomized control trial of liraglutide for adolescents with obesity, you actually notice that if you look at the liraglutide population versus the placebo population, you notice that they actually have a nice reduction in their BMI. But when you actually stop the liraglutide, you can see that the weight gain starts again. So basically, the recommendation for the use of liraglutide is ongoing and indefinite, like with any other chronic illness. And then finally, just to wrap up quickly, you can use bariatric surgery. And here, the indications would include adolescents more than 13 years of age with the BMI or with class 2 obesity and a comorbidity, or a BMI or class 3 obesity without any comorbidities. So bariatric surgery is associated with weight loss of approximately 26% of the baseline body weight at 5 years. Most post-surgical complications are mild. Long-term complications include nutritional deficiencies, osteoporosis, as well as weight gain. And weight regain after surgery varies. In a study that followed a group of adolescents 5 years after their bariatric surgery, showed that 60% of adolescents maintained their body weight, but 8% regained at least 95% of the initial body weight. Again, there's no winning. And if you look at prevention, so I like this diagram that's called the Nuffield intervention ladder. And it basically begins at the bottom. So you provide information, and this is followed by enabling choice. And then you move up to guiding choice at schools, following by restricting choice, and then finally at policy making level, eliminating choice. And if you look, I'm not going to go through this, but if you look at the multiple interventions that can happen at various levels, we need to start looking and thinking about how we could implement some of these very simple measures. So in conclusion, I'd like to say that obesity is on the increase. Obesity in adolescence is associated with a substantial increase in the risk of concurrent and later health consequences that should be evaluated and treated expediently. And as I've just shown, there's no cure for obesity, and it requires lifelong treatment similar to other chronic illnesses. And having said all of that there, I'd like to end by saying that obesity is preventable. With that, I'd like to thank you. So I think it's time for the panel discussion. So I'm going to invite our two previous speakers, Dr. Sokhela and Dr. Harbron, to be part of the panel. But over and above this, I'm going to invite two other panelists. Dr. Tatenda Mawoyo is a qualified social worker with a master's degree in social policy and management. He works as a junior researcher at the Institute for Life Course Research at the Stellenbosch University since 2020. His research interests include adolescent mental health, parenting, sexual and reproductive health, and he's a registered PhD candidate focusing on how school climate shapes adolescent mental health. So a welcome to Tatenda Mawoyo. Our other panelist is Dr. Monika Kamkuemah. She is a postdoctoral fellow at the Urban Better Satellite Studio at the University of Pretoria, Faculty of Engineering, the Built Environment and Information Technology, South Africa. Her current work focuses on bridging the gap between climate change and urban health and devising innovative models of participatory research and youth engagement in environmental justice and health advocacy. Her health interests or her research interests include infectious diseases and non-communicable disease epidemiology. Monika obtained her PhD from the School of Public Health and Family Medicine at the University of Cape Town, for which she investigated the interlinkages between HIV and NCDs in adolescents and youth living with HIV in peri-urban Cape Town. So a warm welcome to Dr. Monika Kamkuemah, and I think she's joining us via Zoom. So welcome, Monika.
Thank you. Thank you very much.
Can you hear us properly?
Yes, I can. It's just my lighting is not so great, so I'll be off camera.
So brilliant. So Monika, I think maybe because you're joining online, maybe we would like to start with you. I hope you've listened to some of our presentations.
Yes, I am.
We know that you work in the Faculty of Engineering and that you devise innovative models, etc. Is there a model that you could actually provide us or take us through with a model that you could come up with that could prevent or treat obesity holistically?
Okay.
Maybe share some insight with regards to some of the work that you've done.
Okay. Thank you very much for the question. I was actually, all the presentations spoke correctly me, especially considering my PhD work before. But currently I'm in the Department of Architecture. So I'm working around what we call human-centered design. So that's thinking of how do we design health into urban planning and into urban spaces. So some of the work that I'm doing right now is around walkability and around having green space, blue space, and gray space. So to have a diversity of the land use in any city. And I work in 3 cities in Africa, so sometimes in Cape Town, and then in Accra in Ghana and Lagos in Nigeria, with young people, not directly on NCDs, but more on how do we mitigate the effects of air pollution in our cities. But this is somehow directly related because the way cities are designed and having clean spaces in cities impacts especially young people's ability to be mobile. in the environment and to actually then engage in physical activity by having a walkable environment. And then also to be able to access affordable and healthy food. Am I clear? Sorry. Yeah, so yes, so basically how we bring it all together is by having that intersectoral approach and having the different environments speak to each other when we think about a socio-ecological model that starts from environmental health and the built environment and the food environment, and then how that then impacts individual behavior. So those are just some of the frameworks that I'm integrating into my work at present. Thank you.
Thank you, Monika. I'm going to put you on the spot and ask you, do you think AI has a role in prevention and or treatment of obesity?
So artificial intelligence. I definitely think so, because I think there's a lot of data that we're missing that can be uncovered by AI. For example, if we think about one of the previous speakers spoke about not having a validated instrument to measure food intake and dietary behavior, for example. So if you think about, for example, there's probably ethics and a lot of ethical complications around this, but we could possibly integrate AI to be able to monitor that. And then have that's kind of an unbiased source where we don't have to rely on self-report. But I'm sure there's a lot of ethical issues around that, but that just came to the top of my head right now. I mean, we already have it with smartwatches, like having that monitoring of physical activity and our heart rates, etc. So I think that's just another step that could be integrated.
AI is taking over the world. Our jobs at risk.
And we are.
Dr. Sokhela, one for you. You prescribed, well, ARVs are prescribed on a daily basis. PrEP is being provided to prevent HIV. Now I'm going to put you on the spot and ask you, do you think we really need to provide or prescribe PrEP in patients where we actually have alternate methods to promote safe sex? Given all the stats that we've just shown, you know, there's an increased risk of obesity, and with that, you're going to have an increased risk of complications. Do you not think that other methods for safe sex would prevent the rise of obesity and HIV?
Okay, so I think the simplest answer is to say there's a basket of preventative methods. And PrEP is one of the options in the basket, right? And PrEP is not for everyone, but PrEP should be offered to everyone, irrespective of a risk of obesity or a risk of overweight, right? The only thing that I want to specify here is that the risk of gaining the weight cannot be made a reason not to give PrEP. It's the same for ART. The reason, the fear or the concern about weight gain cannot prevent a person from accessing PrEP. So it's a basket, and we are choosing from a basket. It might not be for everybody, but it should be offered to everyone, irrespective of the risk.
Sorry, so when we actually see adolescents or adults now, for that matter, how would you, and you prescribe ARVs, what kind of information would you like to give them? I mean, there's a risk of ARVs are now associated with the risk of obesity, as you've actually pointed out. It's also associated with one of the other NCDs, in particular, diabetes mellitus, you know? So do you think that we need to actually focus a lot more with regards to education around obesity and its management so that we could prevent obesity if they are not obese, or we could promote weight loss and thereby prevent diabetes? I mean, you have these two complications when put together actually have devastating consequences on a patient's life, quality of life, on the health system in itself, and as a country in terms of budget. You know, budget's always our problem.
Okay, so we have two colliding epidemics, right? And no epidemic needs more attention than the other. But what I would advise is that before we prescribe ART, we need to take a proper history of the patient, understand the patient's risk factors, and we should explain to the patient or the participant in a clinical trial what can happen, what to expect. And then as we monitor, we keep engaging. Are you happy? I forgot to mention this, that we did a bit of a questionnaire where we asked people their concerns around weight gain. You will be shocked that I don't want to sound like Black women love being fat, but most of them were happy with the weight gain. They did not have concerns around the weight gain. We were concerned, they were not. So you should keep engaging with your patients and find out, where are we? How are we doing? Should we do something like this? We have published guidelines around switching ART if the weight gain becomes a concern. So there is the option to switch. It might not mean that they'll lose the weight, but they will just not gain any more. So you keep engaging with your patient, you educate, you keep the conversation open, and you act if and when there's a need to act.
I think you've raised an interesting point where actually women gain weight, are actually happy. But is this not actually associated with the stigma that came along with HIV? Thin, if you're thin, you probably have HIV. Now that you've actually gained weight, you're actually healthy.
I don't think I'm the only one who should answer that, but I'll tell you this. It's a cultural thing as well. You know, in KZN, when they say stufuza, you know, you feel like, yeah, you are here, you are present. So, and then when they call you skinny, I've been called skinny, and it's actually shaming because you are too thin and you are not the ideal, you know, voluptuous body that they expect. So there's a cultural element to it. There might be stigma, but there is a cultural element to it.
I was about to ask on the cultural. Yes.
I can maybe just add one thing. So this was in a high socioeconomic school where the girls said they in Cape Town on social media, they see these things, they must be a certain body weight, and this is more slimmer. And then they go to their families over the holiday season, and there they complain, the family complain about their weight, so they gain weight and eat and so on. And then they come back to Cape Town, and then it's social media again, and school pressures and so on. So yeah, ongoing.
Dr. Harbron, for you, your co-create project was actually such an interesting one. I mean, if you look at some of the your flow diagrams that were created, they very nicely pointed out to some of the causes of obesity and bringing out some of the etiological factors. And one of them was actually that, you know, social media actually plays a very adverse role in actually gaining weight, and in their you know, somebody said that what they did without data or something like that. There's no life without data. How can we use social media? You know, you've interacted with some of these with some of these adolescents. How can we use social media in a more positive light to actually promote healthier living? I mean, there are lots of adverts, you know, that create bad healthy living, but surely this can be used in a positive light.
It's a difficult question. So I suppose some strategies still needs to be, we need to think about them and test them, but definitely they suggested, for instance, policies on adverts that's on social media. So eliminating the adverts of unhealthy foods and rather promoting healthy. So they were indicating that the adverts are so big and it comes up the whole time and things like that. So you can limit that on a national level, but you need policies in place for something like that. Social media, in another way, that's their way of communicating. So one must sort of use that as well in your interventions or communicating your health behaviors or health strategies to adolescents. But I guess there's more work to be done. You know.
Thank you, Tatenda, for you.
So I'm just going to quickly comment on the previous question. I think right now, for instance, with the Rugby World Cup, we've got an opportunity where we've got a lot of role models, and that could also be tapped into in terms of making use of that opportunity of pushing positive health messages. So yeah, I just thought I would add that.
Yeah, go Bokke. We hope we're bringing back that cup in 2 weeks' time, right? So Tatenda, just a question. You know, I brought up that slide in my presentation on mental health and this bi-directional flow and this vicious cycle where you become obese, and then because you're obese, you develop body dysmorphia, and because you have body dysmorphia, you actually become depressed. With this body dysmorphia, you actually tend to binge eat, and you can develop an eating disorder. It's a vicious cycle that needs to be addressed, right? What are some of the ways that we could, you know, intervene here?
Thank you. Thank you very much for that question. I think the way I'm going to answer that is drawing a lot on helping adolescents thrive. So there's a toolkit on how to help adolescents thrive. And basically, they've got targeted interventions which specifically look at a particular grouping of adolescents, but they also have universal interventions. I'm going to touch a little bit on that, the universal interventions. So for example, if you look at adolescents, they spend quite a lot of time in school. And I think you mentioned earlier on that bullying is such an important issue. So how do we begin to create safe spaces or safer spaces for adolescents so that they're able to thrive? And part of that is if we do that, then perhaps things like bullying are minimized. And there've been trials that have actually showed evidence that things like that actually work. Closely linked to that is support for people that support adolescents. Here I'm thinking teachers in particular. Teachers are overwhelmed. So it's very difficult for someone that's really overwhelmed to pick up on some of these things and intervene quite early. So we need to be thinking about how do we support our teachers? And by the same token, how do we support caregivers? I know in your presentation, you alluded to adolescents feeling that perhaps caregivers don't really understand them and so on. We know adolescence is a very difficult time, but what is it that we can put in place to actually support the caregivers so that they can support the adolescents a little bit more? Thank you.
So thank you to our panel members. So we're now going to field questions from the audience. So if you do have a question, please raise your hand.
There's only one. Oh, you've got
Okay, thank you. Very insightful discussion. Mine is not so much a question. It's a suggestion or just something out there. It goes back to your question about what can we do and how can we use social media and what's out there already. So one of the things, influencers. Yesterday, there was a lot of talk in different sessions on the use of influencers. And we have a lot of young influencers out there on YouTube channels, on TikTok. We can use those to our advantage. And then use things that are already in use. For example, HEALA. We have HEALA, the Healthy Eating Alliance. They're doing a lot on advertising and marketing around the right wording, the right educational information and getting it out there. I think there's also that need for collaboration with existing structures and systems that are there. Yeah, I think I'll stop there. Thank you.
Thank you for those comments. They're well noted.
Good morning. I just want to add to what the someone out there in the front said about bullying. I had actually made notes on that. And I just want to say that, you know, we cannot just talk about peer influences without really going deeper into the different types of peer influences. And bullying is one of them. And what I've always been teaching in my community is that instead of being the smother mother, we should now opt to being the nurturing mother, where we can pick up trends in our children that will indicate bullying that is taking place with our children or maybe friends that they know. And one thing I've picked up about a lot of adolescents in the area where I come from is that a lot of them were binge eating because of bullying. And if it wasn't for the fact that we as peer educators were alerted to that type of behavior, it would have been difficult to pick up that this was a distress call.
Thank you for those comments. So a few comments online. So one of the comments from Anna Houston is that most of my teens who have gained weight on DTG have complained of increased hunger. Oops. Have complained of increased hunger after switching to TLD. Any comment?
I think it's a two-way thing. They are probably having an increased appetite because of the body's demand because they are teenagers. I have a teenager in my house who goes through half a loaf of bread and they are not on TLD. So it's a combination. There's the hunger from who they are. I do not know DTG to be increasing appetite per se, but we know that it causes weight gain. So the appetite might be from every other thing but DTG.
Okay, so the other comment that we have is that social norms like perception of beauty around a fuller figure, okay? And what it goes on to say, I'm still determining whether the hypothesis has been challenged recently in the Ozempic era. So basically, Ozempic is the GLP receptor agonist. And what has happened is that of recent, there has been following social media trends and so-called free advertising for the company at name. The GLP receptor agonist has actually gone out of stock internationally. And what this had done is, so just to put into perspective that this drug in particular, the GLP receptor agonist, is actually only indicated for adults with type 2 diabetes and has not been approved for weight loss. But in these groups, it was noted that weight loss was a side effect, and as a result, it had been abused. And lots of famous influencers went out to say that use this drug and actually you'd be guaranteed weight loss. And as a result, this is how the Ozempic or this era came into being. So the bottom line is that this drug is actually not registered for the use of weight loss, and it is only registered for the use of type 2 diabetes in adults. So it shouldn't really be used by any adolescents at the moment until it's been FDA approved. But it goes back to say your perception of beauty is then being beautiful. I mean, it cultural differences, I suppose. I'm not quite sure if anyone else has any comment to that.
So I'm actually going to pose a question, if I may, really probably to all four of you, including Monika, because I'm very interested in the green space work you're doing, Monika. And I'm going to bring it back to you guys to suggest that, does it make sense then if our treasury took a fraction of the money that Ozempic would cost, or indeed bariatric surgery would cost, to put some outdoor gyms on every green space that you've identified, Monika, throughout the country, particularly in our peri-urban townships and in more rural spaces, and then train some very, hungry for jobs young people to be, enthusiastic sports training kinds of individuals, recognizing that maybe it won't make the very obese less obese, but it will perhaps prevent some of this and address some mental health aspects, get people out active off their social screens a little bit, maybe looking at their social screens to see how to buff themselves a bit more, but just simple outdoor gyms. Is this something that we should really be advocating for? We are the HIV community. We're very good at being activists and advocating for stuff. So should we be doing that? So I'll maybe each of the
Sure.
panelists. Yeah.
Let me start. Be easier. So I think that, you know, it's recognized that physical activity is actually associated with a reduction in BMI. Now, having said all of that there, I think what needs to happen is that the government or people within power need to realize that actually obesity is a problem. And until that happens, we're not going to make any headway. So they're going to be continuing to treat the consequences of obesity. So we're going to work in retrospect. Instead of preventing, we're now going to treat what's going to happen. And it will make sense for us to put a whole budget into the prevention of both obesity and subsequent diabetes. And if you look at some of the data, type 2 diabetes now is the leading cause of death in female patients. And 1 in 3 female patients are actually obese. So 33%, if you want to put it into that perspective. So they need to actually recognize that obesity is here and it's here to stay. But we know that obesity starts from age 5. I've kind of mentioned the stats earlier on. So we need to start to look at preventative measures and how we could actually make sure that our population actually isn't going to become more obese as we progress through. So essentially, simple measures like instituting gyms outside park gyms, gyms within park to promote physical activity would be one of those ideas. In a recent study that actually showed whether dietary intervention combined with physical activity actually made a difference, the answer was that physical activity in the prevention of obesity was better than diet and physical activity combined. So it goes on to say that we need to make our parks safer. We need to add more facilities that our children can use. We need to add more green spaces so that we can make the environment safer.
Sorry, just to add on that as well. So the green space has like multiple.
I think Monika's commenting, but we can't hear her.
Oh, sorry. Am I out there? Okay, I was saying, can you hear me now? I'll leave a comment and you can read it out.
We can hear you. You can go ahead. Monika?
Oh, okay. Sorry, there was a delay.
Yeah, you can. Thanks.
Okay. Yeah, so I was saying the green space has multiple benefits, right? Because it's been shown that just people being exposed to green space, it improves their mental health as well. So on top of that, if they can engage in more physical activity in a walkable environment that has trees, etc., that not only has knock-on effects in terms of their health, physical health, but then mental health as well. And then on top of that, just having a green space, you can have the cost economic analysis to show that this will help government to achieve its NDCs as well in terms of greenhouse gas emissions, because the trees will absorb the greenhouse gases in the air. So it's actually a win-win on both sides. Yeah, thank you.
Yeah, so I agree with all those about the facilities. Also within the schools, it seems like really problematic, the facilities that's currently in the school for sports. And they also mentioned, for instance, the your life orientation subject in schools, they just don't do anything, no sports in that. And there's also no fields anymore. You know, there was maybe 10 years ago or so on, but it's not well maintained. And so there's no one to coach them. And so on. The other thing that they also mentioned, many of the adolescents, is they want music or sort of play musical instruments or musical classes or something. And also so culture, drama, and so on. And dance was the other thing. So they don't just want to do sport, they want to do these other things as well, but there's no opportunities for them. And this then in those graphs, it led then to also the mental health, because there's no socializing or escape in that way.
Yeah, so I think just for me, I think it's a very good idea. And I think what we also need to do is just take the adolescents along in terms of the journey. So it's very important to engage because what we might think are good solutions need to be backed up by what the adolescents think.
With that, I bring the session to a close. Thank you to all the speakers. Thank you to Monika for joining us online. It was a very good session, so thank you.
Thanks, everyone. That was great. We're going to break for tea now, and we are running a little bit late. So could I ask that everyone is back here by, what are we on? Yeah, by 11. So to try and get us a little bit closer back to being on time. Thank you.
Thank you so much.